This is a continuation in our series of EKG Killers, where patterns save lives. In part 1, we discussed WPW and hypertrophic cardiomyopathy. Now, in part 2, we'll go over QT abnormalities, Brugada syndrome, and arrhythmogenic right ventricular dysplasia. Giddy up.
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. Moving on to intervals, let's talk about the QT interval. You don't want it to be too long. Heart conduction can be a bit like road traffic. Everyone knows he's the greatest driver around. But not everyone can be right. Just look around. Going slower than the flow of traffic requires, whether we're talking about the freeway or your heart's conduction system, it can cause bottlenecks and crashing. If the potassium channels on your myocytes take forever to repolarize and there's no traffic, then you can have a restful, easy pace and maybe there's no big issue. But if at baseline your myocytes take forever to repolarize, then any state of stress, exercise, what have you, can force a conduction down an incompletely repolarized myocyte. It's the equivalent of the slowpoke getting rammed from behind by someone going at the normal pace of traffic. And the only sign that you may see is something that we may miss: a long QT on EKG. Well, what causes prolonged QT? Well, the hypos and the antis. Anything that slows you down. So the hypos. Hypokalemia, hypomagnesemia, hypocalcemia, and hypothermia. Prolonged QT. Also the antis. Antipsychotics, antidepressants, antiarrhythmics, antihistamines also cause prolonged QT. You also may be unlucky to be born with prolonged QT. There are at least 15 different subtypes that we know of right now. Just 2 biz-buzz associations. Romano-Ward syndrome is an old term for the various pile of QT syndromes that we now know to have their each separate name for their subunit. Jervell-Lang-Nielsen, on the other hand. Jervell-Lang-Nielsen. Can you speak up? Jervell-Lang-Nielsen is the one associated with deafness. Well, you don't want the QT too short either. The heart needs time to recover and repolarize after conduction and contraction. Although the heart is always there for you until the bitter end, it will constantly beat just for you. There's only so much it can do in a given time frame. It takes time to transmit the electric signal. It takes time to repolarize, and each layer of the myocardium repolarizes in series. The endocardium, followed by the myocardium, and then the epicardium. If there are a few potassium channels here and there that are gunners, and they try to repolarize too early for the group, they may be able to conduct again too early for that group. This shows in an average time to repolarize of shorter and shorter intervals, hence the short QT. During regular business hours, the repolarization is just rushed. But if you increase the heart rate during exercise or some stress, a few early gunner potassium pumps repolarize too quickly and they transmit the next discharge before the group is ready. a type of chemical QRS on T phenomenon that can generate quickly to reentrant atrial dysrhythmias or ventricular fibrillation. So what are we talking about here? Anything that affects the potassium efflux channels. Short QT is like a yappy little chihuahua. Too much all at once. Remember, short QT is caused by the hypers, hypercalcemia, and hyperdigoxinemia. Always check a chemistry, and if the patient's on digoxin, check a level. Unfortunately, you can also be born with short QT syndrome. It's a relatively newly known entity, but the literature we have right now points to a likely autosomal dominant inheritance, so it's totally worthwhile to ask about family members of any age with sudden death. The diagnosis is based on a point system, with points given to how long the QT actually is, clinical history, family history, and genotyping. All of them will be used to give the patient either a low, intermediate, or high probability of short QT. Medical management with quinidine is the first line, and some patients, unfortunately, will need an implantable cardioverter defibrillator. Brugada. We love talking about Brugada, don't we? You know who doesn't like talking about Brugada? Cardiologists. Majorly hating on it. This is a good example of either parallel evolution or selective hysteria or some type of epiphenomenon in which two people may see the exact same thing but have completely different understandings or attitude about it. More on that later. 3 Catalan cardiologists, the Brugada brothers from Barcelona, Ramon, Pedro, and Josep, they were the first to describe a sudden death syndrome associated with an ECG showing a right bundle branch block pattern with bizarre ST segments in the anterior leads. Soon it was discovered that the Brugada syndrome was caused by a sodium channelopathy in which a mutation, often the SCN5A gene, it causes a loss of function of the action potential in some epicardial areas of the right ventricle. Remember how we talked about the fact that gunners are bad for group morale? Well, when there's loss of coordination and repolarization, in this case, a transmural and epicardial dispersion of repolarization, a re-entry circuit can be formed. Since some of the sodium channels in the right ventricle just don't participate fully in repolarization, you see this bizarre look to the right-sided leads. Even a micro re-entry circuit can cause an extrasystole, just at that vulnerable window to precipitate ventricular tachycardia or ventricular fibrillation and sudden cardiac death. So let's make this diagnosis. I remember it this way. A right bundle branch block-looking thing with bizarre ST changes in the anterior leads. The most specific finding is the type 1 morphology, the coved T wave. So you have a right bundle branch block, and the S wave forms a large downslope onto an inverted T wave. The two other morphologies are consistent with, but not necessarily diagnostic of Brugada syndrome. These are the saddlebacks. The ST segment curves down and back up to a T wave, looking like a saddle. Type 2 is a saddleback with elevation. Type 3, saddle, no elevation. So the 3 types are coved, saddle up, saddle down. Okay, you see a patient with right bundle branch block and ST abnormalities in the anterior leads. You're awesome. Admit. Not so fast. Remember how I mentioned a potentially problematic meeting of the minds? Well, to make the diagnosis, we need both EKG criteria and clinical findings. So the EKG criteria, check. We can all learn that. The clinical criteria, however, leave a little bit to be desired. Here is a potential discussion that you may not want to be in. Is there documented ventricular fibrillation or polymorphic VTAC? I don't know, but I fixed whatever it was. Is there family history of sudden cardiac death less than 45 years of age? Oh, that's fair. That's good. We'll make sure we find that out. What's your next question? What are the ECG findings in family members? I don't know because I only have this patient in front of me. I can't register all the family members to meet that criterion. Is there inducibility of VTAC on electrophysiology studies? Like I said, game on for you. Admit. Syncope? Yes. That's what he came in for. Oh, yes. One last question. Is there a nocturnal agonal respiration that was documented? I hope not. Now, all fun aside, what I mean by this is that your patient's presentation and your concern has to be a proxy for the clinical criteria. Consultants are sometimes more interested in being right. Some cardiologists are not familiar with Brugada syndrome because it's really a subspecialty thing. The literature is mostly in electrophysiology journals, which most non-electrophysiologist cardiologists don't read. I mean, to be fair, we can't keep up in every little nook and cranny subspecialty in emergency medicine. The content and knowledge of some specialties, when they directly affect us, can be leapfrogged over the broader specialty audience and land right smack dab in the emergency medicine literature. So you mentioned this cool thing that you're excited about, but the subspecialist is totally not versed on. It's only human nature to see one's own blind side as a threat. So be nice to them. They're coping. This is a good example of just a different focus. Obviously, these guys are experts and they're great at what they do, but their attitude is they play to win, to be right, to make the correct and accurate diagnosis. That is wonderful. And, we love that game too. But often, we just need to play, not to lose. In emergency medicine, we're happy to be proven wrong after the fact when all is settled down. But we have to do the right thing at the right time with the information and resources available to us. Patients with suspected Brugada syndrome should have electrophysiology studies, but in the meantime, beta blockers are often started to avoid dysrhythmias. The treatment plan is individualized to the patient and his risk, with some needing ICD placement, some needing medications. The take home here is this: if you need to, dig in your heels and be your patient's advocate. Okay, we're in the home stretch of the 5 EKG killers. We've talked about many of the oldies but goodies. In part 1, WPW, hypertrophic cardiomyopathy, and in part 2, now QT abnormalities and Brugada. Now for something that's not as common, but just as deadly. If you can catch this, if you can see this pattern, you can save a life. Arrhythmogenic right ventricular dysplasia. A mouthful, but a good one. It's nice when the name tells you the trouble. ARVD is a disorder where there is a triangle-shaped area of abnormal myocardial tissue in the right ventricle, leading to cardiomyopathy and dysrhythmias, which seem to come about around adolescence and young adulthood. Why does this happen? ARVD is an autosomal recessive trait with variable penetrance. So although it may run in families, not everyone is so obviously affected, which makes the age and features of presentation difficult to really nail down. 8 different genes may be affected that cause malfunction of desmosomes. You remember, those are the cell structures that bond one cell to the next. Especially important in cardiac cells to coordinate a contraction. Well, if the desmosomes fail early, then the death of the desmosome tells the rest of the cell, Well, that's all, folks, and cellular apoptosis is triggered. So the whole cardiac myocyte dies because the desmosome kicked the bucket early. What happens to a heart cell when he dies? Fatty infiltration. The degeneration of the cell triggers a replacement of tissue by fatty cells. Well, what do you get now? A weakened area of myocardium that doesn't participate in systole. It's inefficient in pumping blood to the pulmonary artery, and you get a young person with poor exercise tolerance, or unexplained syncope, or unexplained hepatic congestion and lower limb edema, or, more pressing, arrhythmia, hence the name. On presentation, you may treat the dysrhythmia and then scratch your head. Why did this young person go into polymorphic VTAC? You do an exam. No major clues. Family history? Not too contributory. Then you get an EKG and aha, you see something. It's a little squiggly line after the QRS. In the anterior leads, V1 through V3, you see an upward deflection after the QRS complex in a T-wave inversion. It almost looks like a squiggly E from syncope fell flat on its face right after the QRS complex. That little face down E after QRS is the epsilon wave. What do we do with patients in whom we suspect ARVD? Well, we stabilize the unstable, but more commonly they'll come in with compatible symptoms. And you do your EKG, and you find that squiggly E face down epsilon wave. Well, what now? Well, it turns out it's very similar to the other things we talked about, often stepwise, starting with beta blockers and potentially an ICD. Our goal here is to suspect it and detect it, and not send someone home to die from a dysrhythmia. Okay, just to round it out, nerd it up, or better yet, something to know when you're drinking and knowing things. ARVD is autosomal dominant with variable penetrance, as we mentioned. The autosomal recessive version of this is still ARVD, but it's associated with Knox disease, woolly hair disease. These children, usually of Mediterranean descent, will have diffuse, non-epidermolytic palmoplantar keratoderma with woolly hair and cardiomyopathy, aka Naxos disease, named after the Greek island Naxos in the Cyclades, the Cyclades, where it was first discovered, likely from a founder effect phenomenon. Opa. Let's bring it on home. The 5 killers that we can catch on EKG. WPW. Orthodromic, narrow complex tachycardia, looks like and acts like SVT. Antidromic, wide complex tachycardia, treat it like VTAC if unstable with synchronized cardioversion, but procainamide works for both orthodromic and antidromic. If you see an irregular wide complex tachycardia, danger. Do not give AV nodal agents, only procainamide or electricity. In short, WPW, procainamide, electricity. Hypertrophic cardiomyopathy, syncope on exertion, dagger-like Q waves laterally and inferiorly. Get that echo. QT, long QT, is caused by the hypos and the antis. Hypokalemia, hypocalcemia, hypomagnesemia, hypothermia, and the antis, antidepressants, antihistamines, antipsychotics, and antihypertensives. Short QT is the Chihuahua version, the hypers, hypercalcemia, hyperdigoxinemia. Brugada syndrome. We need EKG findings and clinical criteria, but being in the ED for syncope counts. Right bundle branch block and ST changes. The coved version type 1 is the most specific. Beta blockers, ICD. ARVD, Unexplained syncope, that fatty triangle in the right ventricle. It shows up as a squiggly E fallen face down after the QRS complex. The epsilon wave in V1 through V3. Can I get a beta blocker or an ICD? In short, a good history, a good family history, an exam, and an EKG will get you mostly to where you need to be. Dig in with that history, carefully dissect that EKG, and you may just save a life. Thank you for listening. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.